care event, so well attended. Apologies if anyone is here to discuss space policy, but there was a slight shift in the running order. But I'm glad you're here nonetheless. Policy Exchange has published a couple of papers over the past 6 months on social care. The first one we did was in the summer, 21st Century Social Care, which looked at social care funding and the sorts of opportunities that might exist in new technology, in improving care, particularly of elderly people. And our approach, as I think Warwick Lightfoot, our head of economics, will set out, was based on the idea that it's time for a kind of logical completion of the welfare state, and for social care funding to be along the same lines as the NHS, free at the point of use. We've also published some polling, which I thought was just briefly worth mentioning. We asked a couple of thousand people via Delta Poll the following question. The NHS provides free healthcare for all UK citizens free at the point of use. However, social care for the elderly and adults in need is not currently provided for free. Which of the following do you most agree with? And we found that 69% of people agreed with the idea that social care should be funded like the NHS, free at the point of use, free at the point of delivery, and paid for through general taxation. In contrast, the idea that social care should be paid for by people who need it by selling their assets, such as their home, was just 6%. So there's obviously an appetite for fixing this problem. In fact, the Prime Minister has said it is time, in his first speech outside Number 10 Downing Street, he said, it's time to fix the social care crisis once and for all. And we hope at Policy Exchange that he means it. So on the panel, starting from my right, your left, Warwick Lightfoot, who is the head of economics and led our research on this, was a co-author with me and one other of the paper that we published last summer. We have Camilla Cavendish, Baroness Cavendish, former head of policy, head of the Number 10 policy unit, I should say, and most recently the author of Extra Time, 10 Lessons for an Ageing World, which you may have seen serialized, I think it was in the Daily Mail and other places. On my left, Richard Sloggett, who was Matt Hancock, the Health Secretary's special advisor until August. So the man who is inside the most important room for this issue, and can perhaps tell us all about that mysterious green paper, which we were discussing last year, in fact, and it hasn't yet appeared, but we're hopeful that we're on the brink of something exciting. And then on my left, Caroline Abrahams, the charity director of Age UK, an important voice in this debate, and I'm pleased to say has been one of the supporters of our work over the last year or so. Another key supporter who's not here, but who I would really like to mention as a sort of hero of the hour for us, was Jacob Rees-Mogg, now obviously the leader of the House of Commons. He basically, we went to him with our idea for social care to be free at the point of use like the NHS, and slightly to our amazement actually, he agreed and said, yes, I'll support it and I'll write the forward for your report and I'll be the sort of public face for your paper. And he's been arguing ever since. He mentioned our paper in his first appearance at the Dispatch box over the summer, which we were delighted by. And he's certainly, along with, I hope, the Prime Minister, is supportive of reform in this area. So without further ado, I think I will start with Warwick and give each speaker about 5 minutes, then a couple of questions from me perhaps, and then I'll open it out to the audience. So, Warwick, please.
I have been interested in social care and how you fund it for the better part of 25 years. I was, for a long time, a special advisor at the Treasury when Sir Roy Griffiths' report that led to the introduction of care in the community was accepted by the government. It was Mrs Thatcher who did that. And I saw the transfer of what was housing benefit money through to payments for social care through local authorities. And I was actually a local councillor when care in the community was introduced in 1993, and I actually helped Mrs. Bottomley, the Secretary of State for Health, to launch it at that time. And very quickly it became plain to me that we were in a very awkward position, because all sorts of care, medical, clinical care, that was very trivial, and they might not give you, I have a little ganglion cyst there. That's absolutely trivial, could easily be managed. I can have that done for free on the National Health Service. But if I have a stroke with you at the moment, and I fall off down the side, and it's never the same again, and I need a lot of help with everyday tasks, I will have to pay for all of that care until I'm within the hands of the social security system. Now, in parallel to those changes in social care in Britain, there was a very sophisticated debate in the United States about the reform of healthcare. And in many areas of public policy, one of the things I find interesting as an economist, there's a much more acute, a much more developed public policy debate from an economic perspective in the United States than the one we have in the United Kingdom. And some very distinguished economists, led by Martin Feldstein, who unfortunately has just died, set out the framework that you would approach this in a logical way. What you would do is you would invite people and households to pay for their care on a pay-as-you-go basis where you can afford to do it. So when we've got a cold, we go to a pharmacy, we get the Lemsip. You probably would actually invite people to pay for their physician. You would invite people to take out a basic insurance for the sorts of things that an insurance market can work in. But where they're big events, so-called catastrophic events, where insurance wouldn't take care of you, or they're chronic conditions and chronic events where insurance can't work, then you would publicly intervene. Now, we're in a very odd position, because the very things that most of us would be able to do without too much difficulty, it's taken care for free, but some of the most difficult things, complex social care that goes on, is chronic, is continuing, and the very things where we say, well, you're on your own, mate, until you fall into about £24,000 of assets. And this means about 20% of individuals will potentially face this kind of catastrophic clean out of assets. Most of us, fortunately, won't. We might actually spend 6 months or 18 months in a home. It'll be quite a big bill, but it won't actually destroy all our assets. And so I came to the conclusion the only logical thing to do in the UK circumstance was to recognise that we've got to actually protect households against the one risk that they're left with. It's, in effect, it's completing the welfare state that was deliberately left incomplete in 1948 by the Attlee administration when it introduced the National Health Service Act and the National Assistance Act that brings in the means testing regime. There's a further practical reason for this in the UK circumstance, which is this. I have sat on more committees trying to make health and social services work together than many other things I ever did in local government. Most of my time in local government was spent working on social care. And people have talked until they're blue in the face of making the two systems work. And the reason why they don't work is once you're assessed as needing clinical care, you get it for free. But when you're assessed as needing the social care, you have to pay for it, and you have a draconian means test. And it makes it very difficult for local authorities managing the social care to combine with the health authorities of the hospitals. This is why you have disorderly arrangements when people come to leave hospital. It also is part of the reason why sometimes you often have unplanned admission to hospital because the social care isn't properly managed in the community. There are a couple of further things which one should bear in mind, which is that clinical chronic conditions in the community which are medical, have been neglected by the National Health Service. The acute sector has taken a disproportionate amount of services for hospitals like the Chelsea and Westminster Hospital, Derriford Hospital in Plymouth, the Torbay Hospital, those big general hospitals. The acute sector takes a disproportionate amount of resources, and the district nurse service that comes out to manage the diabetic leg ulcer and so on is the part that has over many years been neglected. I don't believe we will be able to make health work, however much money we put into it, until you can actually end this misalignment of cost base and charging. And in the years ahead, unless we actually do this, however many millions of pounds you put in to try and prevent those crises that erupt periodically, you will get absolutely nowhere with it. So within our own framework of doing things, this is the logical way of resolving it, and I don't think you will resolve it unless you do it. In terms of how you manage household risk in a community and where you make collective decisions about where you get that balance, I think it's appropriate to do it. And I'm going to end by saying something about cost. our proposal, which would cost today about £11 billion, which is about 0.5% of national income, just over 1% of total public expenditure. Now, you have a flow of income, GDP, that runs at about £2,000 billion a year. The idea that we cannot afford, within public expenditure, within the way you score public spending, to actually make this upward adjustment in spending and pay for it out of general taxation with no hypothecation is the sort of proposition that people who are unfamiliar with the way finance ministers work in modern advanced economies, as Andrew Dillnot, who investigated this, has said, of course we can afford to do it. It's not a question of affordability, it's a matter of political and social and economic choice. And if you actually project those numbers ahead, in the years ahead, I think that there's a specialist unit at Kent University that does most of the detailed unit cost work on this. You would see what we're proposing probably ending up costing about 0.9% of national income in about 40 or 50 years' time. This is an entirely tractable cost that it's possible to actually manage. And it is worth bearing in mind, you will not be able to say, I'm 67, I'm 77, I'm 85, I've had enough, I want to have care. You go through a very rigorous assessment process. The criteria are laid down. A social services team comes to an assessment about your ability, your capability, and what you need. And the other thing I would say is that social care is something most people don't want in their own home or in a long-term care setting, even when they do need it. It's something that people resist a great deal. And the very final thing I'm going to say, this isn't just about 90-year-olds. My mother's 92. It's not just about 90-year-olds. If you're in your late 30s and you have a massive stroke, you will encounter all these difficulties within the system. As a matter of fact, one of Policy Exchange's former colleagues, best friend, was in this position. When I see Richard and I say, how is your friend getting on? He said, well, he's got through the stroke, but he can't manage very well, and they're having an enormous difficulty organising the care and paying for it. If you're in your 50s and your partner has a very awkward condition like Parkinson's disease, which results in a lot of very expensive care at home and in a home, you will be paying for it out of that household's net taxed income. And you will find that you will be cleaned out, and when you're left on your own, when the partner has died, and you're about my age now in your early 60s, you won't have any resources to meet the kind of everyday things that we'd all like to be doing at my age. And I gave that example in evidence to the House of Lords Economic Affairs Committee in November last year. And I was at a conference in June, and there was a lady who came up to me and said, were you that man who said that? And I said, yes. And she said, you've just described me. I'm in my early 60s. I'm working, I'm past my sell-by date, I'm struggling because my husband was in that position and I was working, and out of our joint household income, we had to pay for all his care costs, and I simply couldn't manage, and I'm still floundering today. So it's not just about the 90-year-old trying to avoid passing on their house. It is about people in middle age and older age who encounter these catastrophic clean-out costs, and I think collectively we should now take that risk on.
Thank you, Warwick. Camilla, do you want to go next?
Yeah, well, sitting next to Warwick Lightfoot is a bit intimidating, really, because he knows a lot more than me, and he knows a lot more figures than I do. Look, I think everybody in this room agrees that the social care system is broken. There are about, I think, at least 12 different models of possible funding being proposed. And the Nuffield Trust, I would say, has also done some really excellent work on trying to bring those together. I just thought I might make a couple of points that perhaps are not going to be made by others on the panel. So I've had a long-standing interest in this issue. In 2013, I went around the country interviewing social care support workers and healthcare assistants in hospitals for the Cavendish Review, which I did for the DH. And actually, a lot of those people said to me, this is the first time anyone's ever come and asked us, apart from Unison, what we think about anything. And a lot of those people are completely disconnected from the system, and they still are. And one of the results of that is that we get the terrible discontinuities of care that we see in old people's own homes. So I was talking to a guy who's 89 who kept a list of every single carer who'd come through his door because he wanted to be able to greet them by name. By the end of that year, he had 102 names on his list. So we need to not just pour money into the same system. And I do slightly worry that some of the debates we're having around this suggest that if we just crank a bit more money in, everything will be fine. I think social care, just as much and perhaps even more so than the NHS, is about relationships, and it is about the humans within the system. So I just don't want us to lose sight of that. So I've been sitting at Harvard as a senior fellow for the last 2 years. Warwick mentioned the States. There is some very interesting work going on there. And after my father died, I started writing the book that Will kindly mentioned, which is called Extra Time, because I actually think that it's not old age that's getting longer, it's middle age. And I think we underestimate how long we have to live, and that is one of the reasons why we don't save enough, we don't plan enough, we don't work long enough. And actually I wrote it partly because my beloved father was incredibly healthy until he was 86. But when my mother left him at the age of about 58, she took the 2 cats with her, and he never got a cat. I kept saying, Dad, please get a cat, it'll keep you company. He never got one because he kept thinking, I don't know how much longer I've got to live. And I honestly think that is just part of what we have to confront here. We need to be much more honest with people about how long we're going to have to live and how do we plan for that. And we probably need to even start telling kids that in school, because of something else I'm going to talk about, which is about our health. Most of the debates we have about social care are about supply. How can we get enough people to look after us? Do we need to have robots? How can we get enough money? We also need to attack demand, because the last 10 years of our lives should not be spent in the sort of ghostly twilight of senescence, and they do not have to be. Some of us will be very unlucky, and we have to remember that, and we have to have a safety net for those people, and sometimes, as you said, in our 30s. But if you go to Ikaria in Greece, or Okinawa in Japan, or many of the places that I visited on my travels, there are 8 different countries in this book, because I wanted to get sort of out of our domestic debate and look at what other people do. You see that the path of true biological aging is not necessarily eating junk food, doing a sedentary lifestyle, and slowly slipping into chronic disease. It actually doesn't always have to be. And I really think our health system needs to be far more optimistic and far less fatalistic about what people can achieve. We don't at the moment in the health service define the line beyond which people cease to be independent. We need to be really rigorous, I think, about defining that line and saying, let's put all our resources into, on the health side, trying to keep people the right side of that line. Strength and balance training has an enormous effect in whether you fall over or not. Whether you fall over or not has an enormous effect in whether you fracture a hip, and that is one of the single biggest indicators of whether you will need social care. But, I'm sorry, I mean, I could talk about this forever, but I've only got 5 minutes. Doctors in both the US and the UK, 9 out of 10 doctors say they won't raise someone's weight with them because they're embarrassed. They also don't think people will lose weight because they haven't got faith. They won't do strength and balance training because it's all a bit, to be honest, it's not very whizzy and it's a bit dull. We have to have a complete revolution in our healthcare system to start actively preventing chronic disease and being much more ambitious about what people, even in their 80s and 90s, can do. So I just say that as a sort of backdrop, because I really worry that that part of the debate is left to one side. And I honestly think that a lot of the graphs that we're all looking at, all the lines are going the wrong way, right? You know, oh my God, we're all getting iller, we're all going to spend more money. We're all actually, because we assume that working age stops at 65, the working age dependency graphs also look really, really bad. But in fact, 1 in 4 people in this country is unretiring and going back to work because they are actually what the Japanese call the young old. They are in fact healthy and capable and productive. And we need to kind of help those people and support them so that we don't necessarily have to encounter quite as many billions as Warwick is talking about. Can I make one other point? Because I'm happy to talk about the funding models, but maybe we'll do that in Q&A. We also are going to need one workforce. So, of course, we need integrated health and social care. So those of us who've been involved for many years, you know, we're all kind of banging our heads. But there are really great things going on, actually, in the NHS at the moment. There's great things going on here in Greater Manchester. There's some fantastic models where health and social care are becoming integrated. But we need one workforce. We need one workforce that talks the same language so that, as you said, we employ the district nurses. We send them into the homes and they can actually talk to the social care workers. At the moment, it is, I think, ridiculous that your husband or wife can give you medication and the social care support worker can't. The insurance models around that are completely crazy. The morale of some of the bravest people in our society, the people who go into the home of a stranger, who make an assessment of what that person needs, who build a relationship with that person, sometimes in 15 minutes. Those people are extremely talented. They don't have the status they deserve in our society, and they are not recognised by the rest of the health system. And we need to have one workforce which is trained in the same way and speaks the same language. And I'll just leave you with one story, if I may. In Holland, I went round, I spent a day with a nurse who had come out of retirement to work for a new model of care which is treating 850,000 people in Holland now. She and her co-workers have a team of 12. They set up their own office, they make their own assessments of patients, and any patient that they see, they go into people's homes, only ever sees three of them. They know those people, and those people know them, and they know their family, and they build relationships with their friends. They give extremely good care in the home, and the reason why retired nurses are coming out of work to work for them is because they're able to give holistic care. We're not segmenting into the cheapest task given to the cheapest person. They're actually getting back to their vocation. Now, lo and behold, that service has better outcomes than the standard hospital care. It also is cheaper. Ernst & Young have done the studies. It's cheaper because the overhead is far lower, because what those Dutch people are doing is giving autonomy to the front line, the autonomy that we have lost in so much of our health and social care system, the autonomy to make decisions, to have lighter touch regulation, and the whole thing is working better. There are some brave people trying to bring this into the NHS. At the moment, what they are encountering, to be honest with you, is that we have a very bureaucratic model. We don't understand an overhead of 8%. We can only deal with an overhead of 25%, and therein lies a story. I should probably stop there. But I think the last point I would just make is, when I've been to Germany and Japan, I was very seized by their models of social care. They are social insurance models. Everyone in this room will tell me that's politically impossible and we shouldn't even consider it. But I did want to just say the politics in those countries has been very interesting. It's taken them each about 10 years to build public and cross-party support for systems which are properly comprehensive. They give proper insurance, they pool the risk, they do give really good care. They do require people to pay in, so it's not the model that Warwick's talking about, which I think is equally very, very interesting. But they have 4 principles, which I do think should underlie any discussion we have. One of them is consistency in eligibility criteria. We know at the moment we do have national eligibility criteria in the Care Act, but they're not always consistent because local authorities can't necessarily afford it. They are transparent, really clear, what you pay in and what you get out. That is a huge reason for public support. A lot of young people in Japan said to me, I don't think I'm going to get a pension. I don't trust the pension system, but I really trust the social care fund. I thought that was quite interesting. They have very clear fee schedules so that providers, we haven't discussed providers, can actually plan years in advance. And the last thing, they are sustainable. And I do wonder whether for all our optimism about fixing this problem and for all the Prime Minister's belief that no one should have to sell their home to pay for care, perhaps we'll get to this, I wonder whether that is sustainable. Thank you.
Well, thank you. I'm actually really optimistic about this agenda, and I think I was delighted that Camilla used the word at least twice in her opening remarks. And I was struck by Will's polling when he said that 69% of the public think that this should be free at the point of use, social care. And actually, the reason we find ourselves in this situation is partly to do with the success of our NHS, which does such tremendous work on a daily basis, which is actually one of the reasons why we are all living longer, and we are all now facing this real challenge of longevity and how we then pay for the care that we all need. Now, some people may say, why are you so optimistic when your job in government was basically to find more and more creative ways of saying that a document is on its way imminently? And I think it boils down to 3 main reasons. I think the first is there is a genuine now acknowledgement across political parties that the current system is not working. I don't think that should be misconstrued, though, that there is not good work being done and good care being delivered across the country. It's not easy. The funding has not been has been challenging, but I think there are some really good, creative and innovative examples of some absolutely excellent services that local authorities are commissioning and that providers are providing. There are some examples as well of absolutely shocking care that we as a society should take very, very seriously, and that's why this debate, I think, arouses such passion and is so, so important. The second reason why I'm more optimistic than I possibly have been in the past is because I think we're moving away from a sort of left-right political axis on this to a sort of, where the Policy Exchange report has landed, on a sort of state-backed solution of some ilk. I think this is far too important a problem to be left to individuals to navigate. The system is incredibly complicated, and more of us are either personally or through family facing these sorts of challenges. So I think we're moving away from that sort of dynamic, which I think is very, very helpful. The other reason, the final third reason why I am more optimistic than I have been, is that there are a number of pieces of work that have been done that have actually started to come up with the solutions. Camilla mentioned sort of 12 different sort of models, but two that I think are very pertinent are obviously the policy exchange work, which has been put forward, which Jacob has supported, but also the work of the House of Lords Committee, which was primarily put together of ex-Treasury members, chaired by Lord Forsyth. And if there is one department in Whitehall that is more sceptical about spending more money on this agenda, it is the Treasury. So to have actual Treasury, ex-Treasury ministers come out and say that a state-backed solution is the right one, with free at the point of use care, is a massive, massive step forward in this agenda. So for those three reasons, I am actually optimistic. Maybe I've drunk the Boris Johnson Kool-Aid this week, but I am more optimistic than I perhaps was. I think the real question now, as always on this, is what happens next and how do we change the system? I think we are getting to a consensus. The key question is how you flick the switch. Two things on this. One is leadership. I think it is, as Will mentioned, absolutely tremendous that the Prime Minister used his first speech to talk about this agenda and to say he wants to fix the system. My former boss, the Secretary of State for Health, has made it one of his 6 priorities to fix the system. The key question now is, what does fixing the system actually mean? And we have been here many, many times before, and Caroline, I'm sure, will talk about that when she comes onto her piece. So that's the first bit. I think leadership here is so important. And I think that leadership and holding those leaders to account on delivery is unbelievably important in this particular time. The second thing that needs to happen next is, and it might sound a little bit fluffy, but I think it's very, very important. The reason why this agenda doesn't progress is because of politics. And what happens is people propose solutions and people find a reason to attack them. And what I think, and we saw that at the 2017 election campaign, and we see headlines around death taxes, dementia taxes, older people's taxes, and we all go right back to where we started, and politicians then put their head in the sand, and we don't progress this at all. And it lets down all of us. So what I think, as we move into an election cycle, at some point, is I think all political parties should sign a clean campaign pledge on social care, where they will not attack other people's policies and actually let them be openly debated on the merits of the policy as they are constituted. And maybe the third sector, led by Caroline and others, can actually encourage those politicians to sign those pledges. I'll leave it at that, and I'm very much looking forward to the... Thank you.
Good morning, everybody. I think it's great that Policy Exchange have posed this particular question, should care be paid for like the NHS? I think it's the right question to ask now, and I think the mere fact it is being asked just shows how far the debate's come over the last couple of years. I don't think anyone would have asked that question 2 or 3 years ago, and the fact that you are able to ask it is partly because of the reports that you've produced, Warwick and Will and others, championed by Mr. Rees-Mogg. That has undoubtedly made a big difference. I think it's helped the debate to become more mature and more informed by people's practical experience and less knee-jerk ideological. And I think that's a very good thing. And for all those reasons, I'm like Richard, I'm actually quite optimistic. I think it's not only right that care is paid for, more like the NHS, but I think it's coming. I think the only question really at this conference is which party is going to take this over the line. which government is going to get the credit for it, which Prime Minister will actually do something that so many others haven't. And I think that's a big question for everybody at this conference to think about, because the benefits of getting this right for millions of ordinary people across the country, not only older people, as Warwick was saying, people in midlife who are very unlucky and either have a stroke or get MND or MS, something that is bad enough to have to cope with on its own without having to worry about whether you'll be wiped out financially or even get decent care to be able to live as good a life as you can for as long as you can. And let's not forget too the 6-7 million informal carers in this country, particularly those who actually stop work to care for either a parent, a loved one, a partner, and do absolutely sacrifice their interests for the future. That's a big proportion of the population. And I think one of the reasons that this issue's come up the agenda politically over the last few years is because more people now know about it directly, because it's someone in their family, it's them themselves, it's their neighbour, it's their friend. And that's why I think it's becoming more and more difficult, even if a political party wants to not act on this, it's becoming much more difficult to do that. Age UK's position, the Care and Support Alliance's position, I'm co-chair of that. That's 86 charities, all the medical charities, all the care charities across disability, old age and care. We've all come together, we talk about what we think the answer is, and we do broadly think this is the right thing to do. Our two principles are that we want care to be free at the point of use. That is like the NHS. We're a bit more open as to how you actually pay for it. Our preference is for general taxation. We're open to a broader conversation. But as colleagues have said, particularly Warwick, we certainly think it's not fair for individuals to shoulder the risk on this, that it would be much fairer and actually much more economically efficient if we pooled the risk, if we all paid in a little bit in one way or other, so that we knew if worse comes to the worst and we need this, either in midlife or much later on, that it will be there for us. But I think there's just very quickly a whole other series of reasons why this is the right thing to do. Firstly, it would create a significant pot of money over time that would allow us to improve the quality of care. What's been said is completely right. There are some great care workers out there. There is good care. But it's a lottery, and you can be lucky and live in an area where there's good care to be had, or unlucky and find that if your mum needs to go into a care home, there isn't a good quality care home in your area. It's too inconsistent. And although there's much more that's wrong with care at the moment, as Camilla said, than just money, money does ultimately lie at the heart of lots of these problems. One of the reasons there are over 100,000 vacancies in the workforce is because the pay and conditions is not attractive enough. And so people don't want to do the job. I mean, there's some marvellous people that do the job, but just aren't enough of them. So money is part of the issue here. Secondly, it would save local government, I think, which is, I'm sure there's a number of councillors in the room who don't need me to tell them how hard it is to meet the needs of your local population without enough support financially to do it. And it's not only, of course, adult social care, children's social care is another huge part of the budget for councils now, but nonetheless, it would be enormously supportive to local government. It is, broadly speaking, what other countries that are a bit ahead of us are doing. Nobody really now thinks that allowing individuals to shoulder this all on their own is the right thing to do. It would, depending on how you frame it, potentially, it would stop people having to sell their houses to pay for care. And the reason that's important, and the reason that I think the Prime Minister is using that phrase, is because if you talk to the public, if you do focus groups, if you do polling, what is clear is that although quite a lot of particularly younger people don't know very much about care, they've heard about that. And the idea that the thing that you've spent your life building up and you want to hold hand on to your relatives might be taken away from you is a source of real fear and anxiety to lots of people. And if you frame this policy in a particular way, you can very much reassure people you don't need to do it. And I think ultimately the reason why we should do this is because it's the right thing to do and because it would be much more humane. It would stop families being caught in the middle between health and care, having to fight sometimes for years to get the support that they should be entitled to. That is, again, hugely economically inefficient. We could do a much better job with a more seamless system. But unless and until we actually bring closer together the way we organise and fund care and the NHS, that's always going to be an uphill battle. So it's there for you. It is there for this party. It's there for all parties, I think, to to do what so many others haven't done in the past. And I just really hope that the fact that we've got such a great turnout today marks the fact that this is the moment for social care and something is going to change.
I think I'd just like to pick up on one point that Richard raised and actually throw it to Warwick, which is that we've been going round in this sort of endless debates. People propose solutions and then other people find reasons to attack them, and we don't sort of move the debate on. I'm going to find a reason to attack you now, Warwick, which is the cost. Your figure for social care funding along sort of NHS lines is £11 billion. It's not a small number, obviously. Camilla has explained how we have an ageing society. Is there not a risk that the costs of this go up and up and up to a point where it becomes unaffordable, and we've set up a system that we can't sort of get out of? Is that a danger?
I think in the United Kingdom, no, because what's very interesting about the United Kingdom is we have many fewer unfunded intergenerational liabilities compared with other advanced economies. And when UK economists and government officials meet at the IMF, the OECD, the European Commission in the days when they used to go there and swap notes on their outstanding bills and their liabilities, the unfunded liabilities we have are very limited. And the other economists will be very impressed. And they say, well, that's extremely impressive. How is it you've managed to contain this so well? It's because the UK's basic state old age pension is very stingy compared with most other systems, such as that in the United States, Canada, and in Europe. The way we contain spending on older people through the National Health Service is extremely efficient at giving you roughly all right care on average, but doing it at a highly contained cost compared with, say, Medicare and Medicaid within the United States. So if we look at all the things we do it very much on the contained cheap, and so we're in a position at the margin to actually recognise we've got to let go. And indeed, most of the other countries who look at us say, well, that's not going to be realistic. You are going to have to raise that old age pension in the way we did with the triple lock. You are going to have to let go in relation to healthcare spending and raise it as we've started to do a little bit. So we have scope, unlike some of our continental neighbours, and arguably even the United States, to actually be more generous and more liberal at the margin, and we're talking at the margin, of the health and social care continuum. And I'll just say this about the United States. Of course, in the United States, if you need long-term social care, the Medicaid system exempts your home, your automobile, and some financial assets from the means test. So that Mr. Murdoch, sitting in New York, will actually have a more generous arrangement than any of you will have from the taxpayer of the United States. So we're in this very odd position where we've got this very, very controlled, means-tested part of social care, and it's why we'll be able to afford it. The sums, in terms of can we manage the present welfare state in the coming 20, 25 years, I think the answer is unambiguously, yes, we can. We've got to make it more efficient. We've got to make the public service more efficient, but we're in a position to do it. I'm just going to change gear for a second. We all mouth the platitude, we're in an ageing society, we're all living longer and longer. Unfortunately, some of the story of that is getting a bit awkward. The King's Fund, the ONS, have shown that the pace of increase in life expectancy is slowing. It's been slowing for 10 years.
No, it's been slowing since 2011, and it's confined to this country in America. You have to be a little bit careful.
No, the King's Fund say that it goes on in the Netherlands, it goes on in Germany, and in Sweden, apparently. I went to Richard Murphy's presentation. The King's Fund shows that there's a slowing of life expectancy. Also, if you look at the actuaries, which have a separate data set, and in
But can I just say, the point is not whether we're getting older. The point is whether we're getting iller.
No, but can I finish the point?
Because that influences when you need care and how much it costs.
May I finish the point? So what you're finding is life expectancy isn't rising as much as it once was, And the interesting thing is whether in the years ahead it begins to go down. Because if you talk to a lot of physicians who've got a lot of experience of looking at their patients, they will tell you people of my mother's age, that cohort, did exceptionally well, but are the cohort coming behind, and it turns on this, who didn't have the wartime diet, the very things that Camilla was talking about earlier on.
Because they're suffering earlier from chronic disease, which is going to put a large burden on the health and social care.
And
So that's why I'm saying life expectancy at birth is slowing. Life expectancy in 65 took a massive leap because we gave up smoking. So between the 70s and 2011, there was this massive leap, unexpected, in life expectancy at 65. You're talking about life expectancy at birth. But all I'm saying, all I'm saying is I just think that part of the reason for this is this burden of chronic disease, which is going to increase.
Well, there's
your
this,
11 billion.
There's this very interesting thing. Are we going to actually have more chronic disease, or are many of us going to be throwing off this mortal coil much more swiftly so that you won't be paying pensions? Well, no, because I think that and remember, the point where you die isn't when you're 85. Most people actually have to bear the thought of it rather earlier. I used to be a messenger in a general hospital, and the porters always said, go into the mortuary and see the list of names, and it's all around your 60s. And if you go to a funeral, you'll be very surprised to often talk to the minister conductor who says, well, I'm off to do 3 more. And unfortunately, it's often people take early retirement. There's a lot of people who retire in their early 60s who don't go early. Because a lot of us have to be cleared out to make up for your father and my mother. No.
On that happy note.
Talk about euthanasia.
On that happy note, I think I'm going to throw the questions open to the audience, but I'm glad we've got some debate going already. Should we have a microphone down here at the front?
No, what's happening is that the rate
Thank you very much.
is slowing.
Yeah.
Thank you.
And could you state your name and organisation?
Yes, my name's Andy. I work for a national support provider for adults with learning disabilities and autism called Dimensions. So I just wanted to initially raise that cohort of people who don't have a catastrophic event in their 30s, they're not in their 90s, they're born with a lifelong disability, and will rely on social care not just to stay safe and well at home, but to get out to make a meaningful contribution and to be visible and valued in their communities. On that note, the long-awaited social care green paper originally suggested that working age disabled adults would be outside of the remit. Richard, could you unpack a bit why that was the decision initially? I know there was some back and forth about whether they would then be in it, but...
So initially that decision was taken, but then it was reversed. I can't comment on conversations in government. Obviously the green paper has not been published. But where I think we've got to is we've had a change of government, which presents a new opportunity. We have a prime ministerial commitment to fix the system. We have a Secretary of State who is committed to fixing the system. We have, an unbelievable, sense of momentum now on this agenda to actually genuinely do something. I think the point you raised, though, is an excellent one, where I think sometimes we look at this problem through a lens of longevity and older people. And actually there is a significant cohort of the population which is growing, which needs care and support at a working age, and there are a whole range of ethical, political and economic reasons why actually addressing and providing better care and support services for those individuals would be better for all of us. And I think that the work that your organisation does and others to keep this on the agenda as these decisions around this policy get developed are going to be unbelievably important. So this isn't just framed as a fixing an older people's issue, it is a wider societal issue. That's very kind of, I'm sorry, I'm probably not projecting my voice very well, so apologies.
Is that any better?
Can you hear me now? Yeah. Terrific. I made an excellent point if you didn't hear me.
More questions and lots of hands up. Where's the microphone? Chap there in the middle. I'll be back.
Thank you. I just, I'm Joe Public, Phil Barton from the local area, but its affiliation is not relevant for this discussion.
Thank you.
The question I had was that a concern for me was that the problem for local councils, whatever party, their funding of social care and social housing, they're already underpaying for the care, so that people who can pay are subsidising those that can't. And part of that was the fact that the policy of minimum wage and rising that at a much faster rate than the councils are allowed to fund is causing a problem. We've just had the announcement that the minimum wage is going up to £10.50. That is going to explode the system and damages some of the figures that have been given about the cost. I just want to add, what are people's view on that?
Thank you very much. Camilla, would you like to...
Yes, I mean, you're completely right. And when I was in government, we put up the national living wage, which, again, while I was really delighted that it actually was helping exactly that group of people who need to earn more, it was really pushing the margins of care providers. So I completely agree with you. It's absolutely vital that that change is taken into account in any of these forecasts. And I guess it's so recent that probably we haven't responded to it yet.
Thank you. Question right at the back there. It's not too far away. Yeah, sorry. Go over there then. Thank you.
Hi, I'm Richard Vautry. I'm the chair of the BMA's GP committee and also a practicing GP in Leeds. And I recognise many of the issues that Camilla and others have highlighted about the impact it has on patients and their carers, and the real stress that it causes, and also the fragmentation between social care and general practice and other primary care services. We have district nurses, who can't do the things that others would do because of their, the particular sort of constraints within their job descriptions. My question is whether the opportunity for the development of primary care networks, which is the bringing together of practices within areas of population of 50,000 typically, provides an opportunity also to build in social care sort of teams within that, working directly alongside GP practices, district nurses, community nurses, solving the funding issues as well linked to that. But also the second question is it time to get rid of the distinction between residential and care homes? Because the people I see in a so-called residential care home are actually in need of as much care as the patients in care homes, but their funding is very, very different.
Thank you. Caroline, would you like to...
Yeah, okay, fine. So there was a thing, I hope my mic's working. There was a thing produced last year that you might have seen called the Nhs Long-Term Plan. Of course, a colleague at the back will know a lot about it. And that contained within it some really progressive ideas about how to support older people to stay fit and well, living at home for longer. And part of the idea that there was to set up multidisciplinary teams which would have care workers in there, but also they would be clinically led, there would be nurses, there would be district nurses, physios, occupational therapists. And they would do a couple of things. They would intervene rapidly for older people who were at risk of having to go into hospital where staying at home might be a better option. And they would also, with people who weren't quite as frail, they would aim to stabilise them so that they didn't then become sicker and more likely to need more intensive care, whether from the social care service or indeed from the NHS. And those struck us as absolutely superb ideas. I'm a bit biased because I was one of the people leading the work, to be honest, alongside the NHS. It was a great privilege to be asked to do that. But the big but here is that none of that's going to work unless we can stabilise social care, because there just aren't enough care workers to put into those multidisciplinary teams. So the vision, I think, for a more joined-up service locally, and most important of all, joining up services around older people, making them much more responsive and fit for purpose, so that you're not just an informal carer at home worried because the person you're looking after is visibly getting sicker, but you can't get the GP out, you can't get an appointment, etc., etc. It would really help with all those things. But again, it's absolutely contingent, I think, on getting more people, more stable workforce within social care. And it indeed, for all those proposals, you'll know better than me, money is obviously a big problem, but the much bigger problem is, are there the people there? Have we got enough nurses? Have we got enough care workers. So thinking about it across the piece is a very good idea, and very much reflects what Camilla was saying too about that scheme in Holland, which I think I'm going to mispronounce. It's the Bergshall scheme, and that is now being introduced and piloted in many parts of England, because certainly in my borough, in England, it
It's
is.
great, but all I'm trying to say
coming.
is they're encountering enormous difficulties, which we need to help them with.
Yeah, it's coming. I mean, certainly the idea of, again, these are all the same sort of ideas, getting professionals much more autonomous, working, knowing their communities and having more time to actually build relationships.
Will, could I just reply to Phil's very interesting question? You're absolutely right that over many years, local authorities have actually used their monopoly purchasing power to drive down the bill they get charged by placing their people into a home. And they actually put in less money into the home on a unit cost basis to keep the home running. It's below what are called efficiency wages. What the homes then do is that when they have what's called a self-funder, they actually charge them above the unit costs of the self-funder to subsidise the local authority placement that's there. This has all been gone into with elaborate care and extremely clearly by the Competition Markets Authority. And when we did our costing, we took account of, if we were going to actually do this, taking on the full bill that arises from the private sector currently subsidising the public sector, so that's within that £11 billion. Of course, there will be increases in wages, but do bear in mind the critical thing is that bill in relation to national income, and as those wages go up, so too you will see national income going up, so the two go up together. So it's the fact that one bill goes up doesn't mean to say that in relation to overall national income and your tax base, it is impossible to actually manage.
Thank you, Warwick. I think we're slightly running out of time, so what I might do is just take a group of 3 questions, and those will probably be the last, I'm afraid. Halfway back there. Yeah, no, just this, yeah.
Sorry.
Thanks. And then we'll come to the lady on the far left, yeah.
My name's Lee Holmes from South Tees Conservatives. I think possibly one of the biggest objections to funding social care for the elderly from general taxation is generational fairness. If you're effectively asking young workers to pay for social care for elderly people, aren't you effectively asking them to subsidise the inheritances of already quite wealthy middle-aged people? And I suspect that might be one of the objections that will be raised to this policy.
Thank you. And then we'll go, if we go to the lady right over on the far left of the room, and then one of these. If you could keep your question to about a sentence, that would be really useful.
I'll try.
Or 2.
Heather Acton, Westminster City Councillor for Family Services and Public Health. And the family services is key. We do look at people from pre-birth to death. So, we really, and we work holistically, or try to, with health. So the Dutch example, it's really important that goes into the local authority because we know our communities. So I want reassurance that sort of thing stays with the local authority. And the second question is, the NHS, the funding is perverse. Acutes are rewarded for the number of people they get through their hospitals. Can we have reassurance that will change?
Thank you very much. And then last question down. Yeah.
Yes, hello, Graham Gooch. I'm the Cabinet Member for Adult Services at the Lancashire County Council, probably the biggest. I have a budget of £500 million. 340 million is for adult social care. My difficulty is when I first saw the question, will it be funded like the NHS, I thought, please God, no. Because I have a population of 1.2 million, I have 30,000 service users, but I have to deal with 5 acute trusts, one mental health trust, 8 CCGs, and I don't think they like each other. And they've all got they all spend different things on different money. It's ridiculous. Nobody's actually looking at the service user to see what they want. We can see the cheers in National Health where somebody who's being treated for mental illness, and then they say, no, it's not. They're autistic. Great. Suddenly they're not a health problem. Yep. They're a social care problem. And it's got to be sorted out. Start looking at the service user and not which part of the organisation deals with it.
Thank you very much. I'm afraid I'm going to have to be very unfair and just pick on two panellists because we're running out of time. Could I come to Camilla and then Warwick?
Could I do the intergenerational one? Because
course,
I'm so glad someone raised that, because that is, I would have thought, the obvious problem with all this. And if the Labour Party hadn't already proposed free personal care because the IPPR did, they would be making exactly that case at the moment. And, you know, everyone in this room would be having to think about it. In Japan, they don't start charging people until they're 40 because they sort of think that's the place to buy in. I think, you know, because of the triple lock, we've now got to the point where average pensioner household income, if you exclude housing costs, is now greater than average working household income. So it will be very, very easy to position this proposal as another bung, as you said, to middle-class rich people who want to keep their homes. And I do think that is a serious political challenge, which it would be very wrong to overlook. The reason I like the German and the Japanese systems is they bind the whole society into those projects. Everybody feels they have the security, they pay in, and we're all going to get old. But there is much more thinking gone into that about actually who contributes. And the point is that everybody is putting a bit in and everybody is getting a bit out. And I do slightly worry, just as you suggested, that if you're effectively taxing 20-year-olds to pay people who are already retired, I think you do need to think about what are the already retired people putting in. And I'm not forgive me, I'm not clear about that. But it's a bit of a political challenge, I would suggest.
Thank you. And Warwick, could you possibly come back on Graham's point as well as...
Well, just start with Graham's point. I mean, you're absolutely right, because part of the difficulty of these one charges, and one does it in local government through social care, and one does it through the National Health Service who doesn't charge. And so this constant row at the boundary. Is that a clinical medical bath, or is it a social bath? And a clinical medical bath is where, say, you've got a complex ulcer that has to be managed very carefully so the wet doesn't get into it. If it's just you can't get into the bath because you can't get your leg over and someone has to help you in, then it's a social bath. It's because you actually have these different funding streams and you've got this different charging stream that lies at the heart of every kind of nonsense that you identify. And it is the way you fund it. Now, in terms of the distributional question between rich and poor, old and young, the welfare state is predicated upon people roughly in working age paying taxes to deal with risks that they otherwise wouldn't be able to manage. And we actually have a very sophisticated a regime here where we collect taxes largely off of those at the top end and help people on low incomes and people when they're young, and we help people when they're ill and when they're old. Now, the logic of your position will be, why should we actually give cancer care to someone who's old? Why should we say that a 57-year-old should have their cancer treated? Why should we say that someone with heart disease at 67 should get that kind of treatment? Because it's in your 50s and 60s and 70s that those things begin to kick in and you need that kind of expense. Likewise, it is worth bearing in mind, we've developed very expensive programs, the tax credit regime and child benefit for people with children and households of younger age bringing up children. Now, those are expensive programs. They're well targeted on what they do, and it's a part of a generational balance. On the one hand, you have to help those who are bringing up families, and on the other, you have to help those who actually face these very big costs at the end of their lives. If you fail to smooth those risks through pooling, you will not be able to help people manage those risks. And if you concentrate purely on the distributional question, you will not have effective welfare services. You get it through the balance of taxation, where we have a high degree of progression within our system. And I know exactly what you're referring to about, it's not just about the old age. This is what I try to emphasize. Exactly, cradle to grave. And there's a lot of people in their 20s, 30s, 40s, and 50s, of the sort that you were referring to, and they're the fastest growing element of the social services budget, as it happens at the moment, who we've actually got to bear in mind. That's why I drew attention to that at the start. But if you actually insist on policies that have a huge distributional bite, You cannot get efficient pooling of risk. And that is why there's been so much damage done in the United States. The US public sector tries to help people, and then it takes it away on middle incomes. And that's why we have a Manhattan skyline of tax and withdrawal of tapered reliefs within the US system. And we've accidentally got into it with child benefit, and we've got into it with Alistair Darling taking the allowances away, and I would strongly recommend that we don't go down that route any further. This is a prize for the Conservative Party. We're not trusted on health. We're not trusted on the welfare state. If we complete this and take it away from Labour, we will be well placed in the years ahead. Now, I've stayed at the Treasury until 3 o'clock in the morning to brief Norman Lamont on why teachers shouldn't have an independent pay review body. I did the briefing on why the haemophiliacs shouldn't get their money. I did the briefing on why the war widows shouldn't get their money. And I see a public expenditure problem coming down the road that I'm going to lose. Now, either you get in there and do that loss and take the credit for it, or it will be a political damage for the party for a generation to come. This is a genuine political opportunity, and as Caroline has said, it's the opportunity to do something that's actually right.
Thank you very much. Do you have a quick response to that?
Yes, I do. Yes,
Yeah,
I do.
you're absolutely right.
Just a very quick response from Richard to the question.
So I'm delighted that people from local government have stepped up to the plate and criticised NHS bureaucracy, because I think that there is a way out of that, which is just because you fund something like the NHS doesn't mean you need to recreate the structures within it. And I think nobody would want to go down that route.
Right, I would love to go on, but I better finish. I'd leave you with two thoughts. One, buy Camilla's book, Extra Time, 10 Lessons for an Ageing World. Also, go onto Policy Exchange's website and find our report, 21st Century Social Care, and you'll find Warwick and my arguments presented there in a highly readable format. And thank you for all coming.
Readable thanks to Will, I might add.
Thank you for coming. And thank you to our panelists. Superb.
Thank you very much indeed.
Very good.
Hello. I'm sorry, but I really don't think that you're... I think
Of course.
that is...
I don't at the moment. No. My post
Oh, thank you. Your question is great. I mean, so I've been talking...